practice. So without further ado, I would like to welcome Shady to talk today. Thank you.
Thank you. Thank you, Samer. And thank you, Artemis, for the introduction. It's a real great honor to be speaking at the Cornea Club. I've seen that group growing, and I think the topic discussed are always of true interest to all cornea and refractive surgeons and even to general ophthalmologists. And wish you the best in growing and hopefully rolling out more and more interesting topic. So again, I'm honored to speak, and the topic, I'm gonna share the screen. Okay, so I hope my screen is showing right, Artemis. Okay, cool. So the topic is new concepts for therapeutic refractive surgery in keratoconus. So the idea is actually to focus more on not just going back and review so many things that's beyond the scope of one single talk, but go over the new concepts that have been developed using also new technologies and new understandings. And based on all these recent studies that made us understand better the treatment of refractive surgery in keratoconus. So first, I'm gonna quickly introduce the key concepts and the key treatments for keratoconus. So one being laser corneal ablation, and that being trans-PTK, topography or wavefront guided PRK. We have stromal augmentation, and that can be corneal ring segments, allogenic lenticules, or corneal allogenic intrastromal segments, or better known as CAIRS. Then we have lens exchange and or implantation. So starting from small aperture IOL to the toric phakic IOL to small aperture implant, and we're gonna touch up on it pretty quick as well at the end of the talk. Now, again, a quick overview of who are the best candidates. Remember here, it's not refractive surgery in terms of cosmetic surgery or in terms of helping just the patient get rid of their spectacles. The idea here is functional rehabilitation of the patients. Typically, these patients are RGP intolerant, or they have a suboptimal corrected distance visual acuity, or they have nighttime symptoms that they can't tolerate, or a combination of all these. We know that corneal grafts in general suffer from a lot of astigmatism. 10% of corneal grafts will end up with large or irregular astigmatism. But guess what? Patients who have keratoconus, 27% will end up suffering large or irregular astigmatism. And that's why for people asking, why would you fiddle with acrobatic refractive surgery since we can just perform a bulk and get great results? Because of that. Because most patients who undergo grafts for keratoconus will suffer from some astigmatism that might be irregular but anisometropic, or irregular, and that's going to be a problem always rehabilitating these patients again. So we try as much as possible to improve their cornea and leave the graft as really the last resort possible. So let's introduce the first concept here in laser refractive surgery. The less, the better. And we're going to show in a minute why and what does that mean. So the less, the better. So the issues in customized laser ablation in general, not just in keratoconic patients, are overcorrection, biomechanical insult to the cornea, remodeling of the cornea, which will bring about irregular healing and sometimes unpredictable refraction, and stromal haze. And in order to avoid these, the best is to decrease the ablation depth and volume. And to be able to do that, we need to think about a way to outsource the preoperative higher order aberration and as well the postoperative lower order aberrations. And this can be done using corneal ring segments, spectacles, implants and lens-based procedures like toric phakic lenses and other implants, and as well laser ablation. So overcorrection typically can happen because of a refraction input that was not accurate, and we're going to discuss in a minute exactly what that means. Laser adjustment, so the laser tries to adjust to what we are incorporating, and that can lead to overcorrection and the biomechanical remodeling of the cornea. Again, garbage in, garbage out, and that's why the refraction we input is vital for the results we're gonna get. We remember always that sphere is the focus plus spherical aberration plus many other things. And the cylinder we incorporating from the phoropter is astigmatism as well as coma and other higher order aberration. So we have to always keep in mind that whatever we're incorporating from the phoropter is actually a combination of lower order plus some higher order. And in order to keep the higher order at the minimum, the best in keratoconic patients is to refract with the light on. So this will bring the pupil a little bit down, decrease the input of the higher order aberration, and will increase the contrast of the patient. So patient can really give us a better idea of what's better, option 1 or option 2. So this will also decrease the confusion area for the patient. And again, let's not be trigger happy. If we can get the patient with a certain vision with a minimum of an astigmatism, for instance, let's stick to it instead of just keep increasing the astigmatism, because if we keep increasing the astigmatism, that is likely to incorporate higher order aberration like coma. So if we can get a vision of 20/40 with 2 diopters of astigmatism of cylinder, basically, that's probably better than a 3 diopter giving almost the same thing, because the 3 diopter will have coma and secondary astigmatism as well as the lower order astigmatism. This is an example of a patient with plano -2 at 50 in the phoropter refraction. If we look at the topography and decompose the topography and look first, at the SIMK, we can see that the difference is 2.81 diopter from the SIMK. If we decompose the cornea into higher order aberration, we take a look at the astigmatism, and that's supposedly incorporating regular astigmatism, but we know now more from our previous experience and from Damien Gatinel that this also is incorporating some higher order aberration. But until Damien Gatinel's classification and new model is out, that's what we have right now, and it's better than nothing. So the astigmatism is 1.86, minus 1.86 at 41, while the coma is 0.82. So our refraction of 2 diopters at 40 is almost similar to the astigmatism, which is 1.86. And we know, hence, that we're not incorporating too much coma into our refraction. By the way, this is taken at a pupil at an optical zone of 4 millimeter, which is ideal in simulating the refraction of the patient, as opposed to larger pupils. Again, we need to keep in mind that corneal haze can develop the more the depth of the ablation. So that's why it's important to keep the ablation to a minimum. And finally, corneal integrity. The more we ablate, the more we weaken that cornea. Again, the final mantra here is the less, the better. Another concept is, should we do combined or sequential custom PRK and cross-linking? And that's the never-ending controversy and debate. But we're gonna show that we don't like dogmas, and there's no wrong or right here. So combined versus sequential. So let's explore the advantages of each. Combined has as advantages that it's one procedure for the patient. It is it provides more optimal cross-linking because the Bowman's layer is ablated, so more riboflavin penetration. It has predictable tissue ablation because this tissue has not been tampered with. The cons of performing the simultaneous is that it is an unpredictable in terms of biomechanical change after cross-linking. It is the successful of the cross-linking is not guaranteed a priori because we haven't performed the cross-linking yet. So we're assuming that the cross-linking will work for that patient. And question mark, are we having more haze? We're gonna review that in a minute. What's the advantages of the sequential? Well, it ensures biomechanical strength at first. So we cross-link, then we perform the treatment. Cross-linking, the changes in biomechanics are accounted for. Whatever the cornea is gonna flatten, change, it's already been done before, while now we're revisiting the cornea with excimer laser. Question mark, at least to less haze. Again, we're gonna revisit that concept in a minute. The disadvantages is that it's 2 procedures, and guess what? Sometimes they are separated for 6 months, or at least 6 months, because we need to wait for that cornea to stabilize, and that's not a luxury that a lot of patients can afford. We have we are losing the very tissue we cross-link, because we cross-link, then 6 months later or a year later, we revisit and we remove the top 50 microns or 70 microns or 40 microns of cornea, which is the strongest, as we know, because the effectiveness goes down almost exponentially as we go down. So that's also not something good. And finally, the tissue ablation rate varies because now the cornea, the stroma has been cross-linked, so the adaptation to the response to the laser is different than virgin cornea. And guess what? This is not only for lower order aberration, but also for higher order aberration. So those of us who have a nomogram for the lower order aberration, that's not enough, because if we are accounting for coma and spherical aberration, that's also going to be affected. But again, Farhat Hafezi and also in another study published by Theo Seiler have adjusted that rate. Some of them are incorporated, built in the laser once you check that cornea has been cross-linked, and that's about 12%. That's already built in. But again, this is merely an average. We know that some corneas cross-link much more than others, and that means that it is not very accurate, and it's just a regression analysis that we're using right here. Again, Farhat Hafezi has shown that some corneas respond dramatically to cross-linking, some of them with severe haze and huge flattening after cross-linking. And again, sometimes combining cross-linking with PRK cannot predict these unpredictable changes that some corneas can develop, and that can lead to severe hyperopic changes. Again, that's a limitation that we might account for, and I will show in a minute how. So let's review the literature real quick and see what has been done with sequential versus combined. And the initial study by John Candelopoulos, I'm sure all of us are aware of this study published back in 2006 in JRS, and another study also for George Quinones show that combining the treatments were as good and actually a little bit better than performing sequential treatment, with actually less haze and better improvement in uncorrected and best corrected visual acuity when we combine versus when we perform sequential, but both work pretty well. Interestingly, however, there's a completely different result published by Marconi Santiago. We're actually looking at the effect of combined. They call it sequential, but they meant combined. Again, showing a lot of haze developing 23% grade 2 and 3.8% grade 3, with 27% losing 2 lines or more and 23% losing 1 line and more. And that's really unacceptable. By the way, in the study, mitomycin C was used for 40 seconds, while in the study by John Candelopoulos and George Quinones, the mitomycin C was used for 20 seconds post-op. Finally, the 10-year outcomes from John Candelopoulos for those same group of patients 10 years later kept showing stability of the treatment, most importantly, and no more haze than what has been reported back then. Bruce Allen from London has shown also that combining wavefront-guided transepithelial PRK with cross-linking without using mitomycin C did not lead to any corneal haze and was very effective. Published in JCRS a few years ago. So should we treat combined or should we treat sequential? The issue of haze, I'm going to answer it in a couple of slides, but I'm going to say that both look to be pretty good. It all depends on the cornea we're dealing with and on the type of patients and final outcomes we're looking for. So if you look at this cornea, we see that this is a cornea so advanced that I'm not going to let the patient wait 6 months to 1 year before performing another procedure, and I would go with combined. But guess what? For those who are skeptical and are saying that the cornea might flatten a lot and change the lower order aberration, we don't care about lower order aberration. Just as we said before, our main aim is the less, the better. We want to regularize this cornea. We don't want to spend precious stromal tissue just to decrease a myopia or decrease astigmatism. I can do that with a phakic lens. I can do that with spectacle, with a contact lens, or whatever. I want to invest the stromal tissue into regularizing the cornea. We can always revisit the cornea later if we want. So this cornea, it will be ideal to perform combined treatment. However, this cornea of a vision probably of 2040, 2030, 2025, I would cross-link alone and then later decide if it needs any kind of custom PRK 6 months to 1 year later. If this cornea was -2 and maybe -1 astigmatism, and then ultimately after cross-linking, this cornea might end up plano with one diopter, that's great. And then I can do a PRK if needed at all. So that's the that's how I distinguish which patients or which cornea need what. Now, should we use mitomycin C when performing combined PRK and cross-linking? And that's concept number 4. Now, we have shown in a study published in JRS in January this year that actually combining cross-linking with mitomycin C, let alone PRK, so PRK is no more a confounding factor, actually led to severe haze. And in this study, we published 1-year results. I'm seeing these patients 2 years and 3 years now, and actually the haze is even worse, and the flattening is even worse. So we are about to submit our data combining PRK with cross-linking with mitomycin C versus PRK and cross-linking alone. And again, there's a huge difference in haze, where PRK and cross-linking alone has almost a same profile of haze as cross-linking alone, as opposed to PRK cross-linking and mitomycin C, where we have a lot of haze, a lot of flattening, and really some loss of best corrected spectacle, best corrected visual acuity. And again, we have some really great scientists who helped us even forge the formula, the molecular formula behind that. But the reason we think why cross-linking and mitomycin C do induce haze and not actually decrease haze, because we have a lot of keratocyte kill, a lot of keratocyte dropout, enough to produce a massive inflammatory reaction. Rohit Shetty has developed a molecular, an in vivo model for it, a cellular model for it to explain that. But basically, we have a lot of release of cytokines and chemokines that are actually inducing stromal haze instead of actually decreasing haze. And again, we have used our proprietary software, which is patented and is already available on octanalysis.com. We have published that very same software in AGO and in Cornea, where it detects automatically the demarcation line as well as the amount of haze. And by applying the software, we could be very objective instead of the Fantasy classification. So we did not rely neither on human subjectivity nor on lighting or background illumination. So we use some artificial intelligence, machine learning based model to look at haze before and after. And again, this is a screenshot of the software where the software detects automatically the demarcation line, that detects the corneal haze, and then can give us all kind of statistical data on that. So again, so the verdict is don't choose mitomycin C. I don't choose mitomycin C. It's been, when I combine them, more than 2.5 years, and the results are really fantastic. Now, how about topography guided or corneal wavefront guided PRK versus ocular wavefront guided? And that's concept number 5. So quickly to summarize, what is ocular wavefront guided? All of these, by the way, technologies cannot be done until we combine with cross-linking, whether sequential or combined, of course. So with the ocular wavefront guided, it's a holistic procedure. It measures the total ocular wavefront. The cons, however, is limited by the pupil size. And if the pupil size is not large, well, it's not good to apply it for keratoconic patients. Plus, the resolution of these ocular wavefront is not good, and the dynamic range is not good at all, unless we're using pyramidal aberrometers. So these aberrometers sometimes suffer from aliasing with large aberrations, and that's why we need latest generation of aberrometers like the pyramidal aberrometers to be able to do that, of course. Another disadvantage is that it might treat unnecessary internal aberration that might be changing as well. With topography guided, the advantage is that it derives the data from the cornea, and it is definitely high resolution. And we know the cornea is the essence of the problem. The only disadvantage, it lacks refraction data, and at the same time, it's rigid in terms of selecting the aberration. We can't really slim it much. We have to deal with what we have. We can slim it in terms of refraction. We can change the refraction and we can slim it. But that's a pretty solid option Corneal wavefront guided is essentially a topography guided. What we do is actually we derive the topography from the cornea, and then we derive the wavefront measurements from it. So we end up having a wavefront segmentation, like spherical aberration and coma. And by doing this, we might be able to slim the aberration profile, like we're going to show in a minute, by taking off aberrations that we think might not be important and leaving aberrations that are more important. But essentially, it is a kind of a topography guided. And even though it might be centered on the pupil in terms of aberration, while the treatment might be centered on the vertex, but we can easily shift the aberrations and let them be centered on the visual axis again. So it can almost simulate a topography guided treatment. Finally, PTK ablation. The advantage of the PTK is that it can treat partial aberration. It can treat partial coma or partial secondary astigmatism. It's a tissue saver, especially in some corneas where we don't want to shave a lot of tissues, or when a cornea has very minimal changes, so we don't want to end up changing a lot by doing a topography or corneal wavefront guided and changing the refraction. The disadvantage, again, is that we don't have a full control of how much we're treating, and of course, we don't have a full control of the refraction as well. All of these technologies will benefit from integrating the diagnostic measures. So it's nice to have all these, ocular wavefront, topography, corneal wavefront, and be able to integrate them to choose the best treatment for the right patient. So as you see, if you have an aberrometer, and ideally a latest generation like a pyramidal aberrometer, and if you have an OCT-based topographer, ideally also something like a Placido and OCT, then you can measure the posterior curvature of the cornea using OCT, which has much less artifacts than a shine flow camera. And then at the same time, you have a latest generation aberrometer where you can scan the whole aberration of the eye and decide what's the best in that specific patient. Again, all this is not a must. It's a luxury, but it's nice if you want to push your customization for keratoconus patients all the way to the max. Again, high dynamic range aberrometer, like the pyramidal aberrometer, can scan as much as 45,000 points on a 9mm pupil, of course, and it has much less aliasing when it comes to large values than the older generation aberrometer, like the Hartmann check and the churning. And again, being able to have all these technology, you can segment your aberration into ocular, anterior corneal, and internal. So if you have a Placido and an aberrometer at the same time, you can segment these aberrations. And you can tell, for instance, that in this specific eye, you have some coma in the anterior cornea that is negated by the internal coma. As you can see, they have a difference in axes, and you end up with much less coma in the ocular coma than the anterior corneal coma. And again, ocular wavefront do account for the posterior curvature by the same token. Now, let me give you an example. What do I mean by this? This is a treatment plan for a corneal wavefront guided treatment. So this is like a topography guided treatment. And on the right-hand side is a treatment plan for an ocular wavefront guided treatment. So if you look at the ablation depth in here, the volume is 950 nanometer. The 39 microns ablation depth feed is almost the same as here. Now look at the ocular wavefront of the same patient on the same diameter of treatment, the ablation volume is less. And even though the final treatment of the periphery is almost the same, but in the center is definitely less, is in the 25 to 30 microns. So interestingly, for the same patient, the ocular wavefront is ablating a bit less than the corneal wavefront or the topography guided. Now, this concept has been reviewed by Bruce Allen in a study in JCRS, where he compared corneal wavefront to ocular wavefront, and he discovered that on the same eyes, corneal wavefront has 44% more tissue ablation than ocular wavefront, or vice versa. So basically, ocular wavefront has 45% less tissue ablation than corneal wavefront. Now, why is that? The reason is actually in the index of refraction of the cornea the aqueous and the air. So as you see here, this is the anterior instantaneous curvature, and that's the posterior instantaneous curvature. And in keratoconus, they both suffer from coma and from steepening inferiorly. But as you see on the anterior, it's sitting on the air versus stroma. Or so basically what you see on the posterior, it is sitting on the stroma and the aqueous. So even though here, even though always the changes derived in our refraction and our patient's vision are derived mostly from the anterior stroma, but actually the posterior curvature negates the anterior stroma. So what we see here typically is a coma, but we don't have negative coma. So a coma that is actually 180 degrees away than the stromal coma. If you have this kind of modality, look at all your keratoconus, and you'll always notice that the posterior coma, if you have an OCT-based tomographer, you will always notice that the posterior coma is 180 degrees away than the anterior coma, is subtracting the anterior coma most of the time. And that's interesting, which means if you incorporate the total coma of the anterior and the posterior curvature, you will have less coma to treat than if you look only at the anterior coma. And that's the advantage of doing either a holistic corneal wavefront guided treatment or holistic topography guided treatment incorporating anterior and posterior, which is still now not available commercially, but will be available soon with the availability of OCT derived topographer. Or if you're performing what's available now, ocular wavefront guided treatment, but using the latest generation like the pyramidal aberrometer. So as an example, this is a patient that has had cross-linking before, and he suffers from some haze. So we really need some good OCT-based tomography to be able to visualize the posterior surface pretty well. And as you see here, again, you have the posterior curvature, the anterior curvature, just like I showed you before. And look, this is the haze, the stromal haze, and that you can see by slit lamp and OCT. So I don't trust my shine flow camera. I trust only OCT-derived tomographer. And as you see here, the anterior coma is 0.86. As you see, the posterior coma is 0.41, 180 degree away at 285. And the total coma is actually 0.97. And that's by the OCT and placido tomographer. Now, if I want to treat, let me go back here. If I want to treat only by anterior topography, just like I have in the traditional topographer, I will end up treating the anterior coma, but guess what? The posterior coma will be unmasked. And then I'm going to end up with the same amount of coma, but 180 degree away. So the patient won't have any benefit. So let's look at the same pyramidal aberrometer of the same coma. And as you see, same thing, and the total ocular higher order coma is actually 0.46 at 92, almost the same as the total corneal coma incorporating anterior and posterior. So in that specific patient, I elected not to perform topography guided or corneal wavefront guided because now I'm limited with the anterior surface, and I performed ocular wavefront guided in this specific patient because I knew it's going to give me almost the same as if I'm treating the total anterior and posterior coma. And interesting here, this is the so ocular wavefront guided. This is the pre-op and post-op topography. And as you see, I have a decrease in my coma. I have an improvement in topography, but not a lot, not a full improvement. So, however, if you look at the aberrations, you can tell that the anterior higher order aberration is 0.39, but the total higher order coma is 0 because it's actually negated exactly by the same posterior coma that is exactly at 180 degree away. And I got exactly what I planned. Should I have treated by topography guided, the patient wouldn't have happy. He would have told me it's the same, but now the smudging is not vertically, not up, but now it's down or whatever. So that's a way, if you, that's the new way to think. We're customizing even our customized treatments. We really want to see, just like we're customizing lenses. We think, okay, this patient needs to have a 0.9 spherical aberration. This patient needs to have 0.27. It's the same. We shouldn't be, we shouldn't stick to one form of customization. Ideally, we should have all kind of customization. Every patient would be treated differently. So in this case, ocular wavefront is definitely part of the armamentarium. But I think, should we have a total or a holistic corneal wavefront or a holistic corneal topography guided treatment incorporating anterior and posterior, and that's now easily available from OCT devices, then it will be probably the best, because I wouldn't be limited to the pupil. I could treat right on the vertex and so on. I would have much more things to deal to plan with. Now again, would I do transepithelial PRK or alcohol or mechanical PRK? That's another good concept. And so transepithelial ablation, if you're not looking at the epithelium, you're not doing refractive surgery. And that's what Dan Reinstein says. And the minute I got my OCT machine and I look at the epithelium and I think I'm a different surgeon, I consider myself now a refractive surgeon, because again, the epithelium has so much to play with, and I can't believe we've been doing, at least us, not of course Dan, but I can't believe we've been doing for 15 years or maybe 20 years refractive surgery without looking at the epithelium. And I think right now it's a must, of course. So the epithelium is a masking agent. We all know that. But look at this, at those three keratoconic cornea. This one has a central cone, and as you see, the epithelium is thinnest at the central cone, right? Now, this one is a central cone, but with a cornea ring segments. And as you see, the epithelium is really thick between the ring segment and the cone, and that actually is contributing to the flattening we're getting. So that's important. And in here, we're actually having a decentered cone. And as you see, the epithelium is thinnest over the decentered cone, while it's actually pretty regular here. If you're performing transepithelial PRK and without really looking at the differences between the epitheliums here and there, you're gonna end up with doubling the treatment. And I'm gonna show you in a minute what I mean by that. But again, if we're doing transepithelial ablation here, it would be nice to be able to look at multiple measurements. And we have to keep in mind that the OCT is different than the excimer laser. In the center, both will give us the same measurement, but at the periphery in here, the cornea is tilted as you know, and the OCT will give us the normal thickness, so the thickness normal to the epithelium, while the excimer laser will give us the epithelial thickness vertical all the way down, and that in the center is almost the same, but the periphery, there's a big difference. So the laser is calculating a different thickness than what we have in the periphery. And if we are incorporating blindly the treatment from the OCT to the corneal laser, to the laser machine, that's a big mistake. So we have to account for it. And again, this is the epithelial map after corneal ring segments, and then you can tell the thickening that happened inward to the corneal ring segments. And it would be nice to be able to incorporate multiple points in our laser machine in the center and the periphery, and then let the laser machine triangulate the differences between all these epithelial modality, instead of having just one in the center or the one in the center and one in the periphery. Even better, it would be nice to have a complete registration. Like if you have your OCT machine, it will automatically take the epithelium and plug it in your treatment. Now, mind you, especially in this case where we have the cone really away, because putting 5 points is not yet enough to predict the epithelial point, but it will be pretty good. Now, the aim is not to ablate the epithelium. No, we want to ablate the epithelium, keep the same shape, and go down to Bowman's layer and translating the shape of the epithelium to Bowman's layer. So many surgeons think, no, we just need a profile that ablates the epithelium. Not at all, because the epithelium here, especially in keratoconus, is our friend. So it has camouflaged so many irregularities that the real cornea is showing, and that has been shown by Damian Gattinel, Dan Reinstein, and Paulo Vinceguerra. So in here, we have to replicate that epithelium all the way down, because again, if we don't take that into account, we might end up with hyperopic treatment. So sorry, hyperopic shift, myopic shift, coma, small optical zone, and tilt. Tilt is not important, but the others are important. And that's why it's important to be able to replicate the epithelium. Again, this is alcohol PRK. And as you see, if this is the epithelium and I just remove it, I end up with much worse corneal surface. The corneal surface is okay now, it's irregular, but it's much more irregular underneath that epithelium. However, if I perform transepithelial PRK, so I'm replicating the cornea, the corneal shape, the epithelial shape all the way down, and then I'm left with a much smoother cornea than what it is should the epithelium be removed by mechanical or alcohol, just like as you see here. So even if we perform a transepithelial PRK that is not customized, we will end up in a better corneal shape than if we perform an alcohol or mechanical mediated procedure. And of course, mechanical will be better in keratoconus because of corneal haze with alcohol. So again, transepithelial PTK now, not PRK, transepithelial PTK versus any form of custom PRK. Let's see, what do you think? So again, transepithelial PTK in keratoconus. This is a decentered cone. This is the sagittal anterior curvature. Now, this is the same, but this is a tangential anterior curvature. As you see, you can look at the cone and know what it is much better than axial. So I don't look at axial anterior curvature in keratoconus when I treat. I want to follow patients based on instantaneous or tangential curvature. What is better is the Gaussian anterior curvature. That's an old concept that is now revisited. We'll talk about it maybe another time, but the Gaussian is really good in terms of locating the cone. And as you can see here, look at epithelial mapping, it is smack down to the Gaussian. So I'm gonna show you one more time all these different maps. Tangential, which is pretty good. Gaussian, which is actually better if you just wanna locate the cone. And then epithelial map, which is kind of smack on the Gaussian map. So if your topographer has Gaussian, it's even better if you want to locate the cone. If some people perform the track, which was introduced by Ricciardi, and I think it is ideal, or even the StarX developed again by Miguel Rishishi and Cosimo Mazzotta. And I think this is ideal to look at the Gaussian map, not only tangential, which is the tangential is already great compared to axial, but Gaussian would be great to locate the cone along with the epithelial map. And you can see how they coordinate with each other. So again, this exact patient, I had a dilemma. Should I do transepithelial PRK? But if I do transepithelial PRK, I'm gonna start ablating 53 microns. I will end up ablating at the cone the difference. And what's the difference? It's about 12 microns. So my laser is gonna ablate more because it's gonna treat coma. And if I do transepithelium, it will ablate 11 to 12 microns more. I might end up over-treating the coma, doubling the treatment of coma. So look at the ablation map, and exactly as you see, most of the pulses are landing on the cone. So look at how much I'm gonna remove, 13 microns, sorry. So I'm gonna end up treating 13 microns. So if I do transepithelial ocular wavefront guided treatment or corneal wavefront guided, I'm gonna end up treating 26 micron, and that's gonna double the treatment of my cone, let alone removing a lot of tissue. So in this case, I had two options. If I have great epithelial scanning modality in my laser, which is not on the market right now, I will include it, but I don't have. So either I want to perform epithelial PTK, which I will discuss in a minute, or I will perform a mechanical epithelial removal with customized PRK. In this case, I elected to perform a transepithelial PTK with cross-linking. So because I found out that the treatment is about the same, 30 microns and 12 microns. This is the ablation map. This is the epithelium map. The ablation map is smack down to the epithelium. So I'm good. I think both will give the same results. And that's exactly what I did. A transepithelial PTK on that patients with simultaneous cross-linking. And this is the topography I got. Much more flattening, less coma, and a 2-line improvement in best corrected visual acuity. So that's how it really can help us by shaving only 13 microns of stromal tissue. So again, now, one interesting concept I'm introducing, does smaller optical zone really result in shallower ablation depth? Most people would think this is a no-brainer. Yes, it does. Well, I don't think so. We're gonna show how and why. So again, that's what I call the Athens paradox. We all know the Athens protocol, and I think it was a great protocol to launch the therapeutic refractive surgery. I think we should give it a lot of credit, but I think it's time to get over some at the time were great, and I think they're still amazing, but we need to now, build on it. So we will build on Athens protocol, and I'm introducing the Athens paradox. So this is the topography, again, of the patient. When you look at it, a central and a bit of inferior steepening down. And the refraction of the patient was minus 4.5, minus 2.5, and 155. And that's the ablation map on the right-hand side. Now, if we try to, one of the lasers that I'm using can play with tolerances in refraction to decrease the refraction as much as possible to give us the lowest stromal ablation possible. And that can be done on any laser, either manually or automatically. And here we can do it automatically, but it can be done manually as well. And as you can see, by taking these off and let the software look for the lowest stromal ablation and give me the lowest possible refraction, the refraction that gives me the lowest stromal ablation. This is what I got. And that's pretty good because I'm treating the astigmatism still, but not as much. And I'm not treating much of the coma because I care about decreasing the stromal ablation. And sure enough, the stromal ablation decreases from 77 to 37 micron. That's a whole lot of shaving. And as you remember, the less the better. And that's what I'm gonna get at, because I don't care about treating the patient's lower order aberration. But if some are taken care of by the ablation, by the customized ablation, then that's great. And that's what I can see here. So for that patient, the ablation on the cone is 35 microns. Of course, the ablation away is 37, and the ablation in the center is 24. Now, if you look at the optical zone, it's 6.7. Now, let us see what happens if I go to the 5.5 millimeter optical zone initially introduced in the Athens protocol. You would assume I'm going to get a less ablation. And guess what? That's the 5.5, and the ablation is still the same, if not a bit more, 37.6 microns on the cone. And again, on the periphery 38. Now, that's interesting. And how is this possible? You know, we thought by Bono's formula, I need to get less ablation depth. Now, let me show you why. So this is the treatment, and that's the ablation pattern. It's customized ablation pattern. So it doesn't follow the typical Monroe formula. And if you look at what is embedded, just embedded in terms of sphere and cylinder in that ablation, let's assume it's minus 1.5 at 1 diopter. Now, if I enlarge my optical zone from 5.5 to here 6.5, let us say, I get larger optical zone, but the treatment is the same because this is an embedded spherocell. It's embedded in the acrobatic treatment to treat secondary astigmatism and coma and so on. It doesn't change, the depth doesn't change. I just increase in volume, but not in depth. And as Paulo Vichuera showed us, volume is not as bad actually because we're not weakening the cornea at a small optical zone, and it might be actually protective against extraectasia. But now let us say that I decided to treat the lower order aberration of that patient. I want to improve them more, and I decided to treat an additional -2 diopter of myopic ablation. And that now is dependent on the optical zone. And as you see, I have a whopping increase in my ablation depth. And that's exactly what's happening. So I'm going to show you one more time what I mean by that. This is the same patient, by the way, and that's the ablation map. And that's the patient. Not a whole lot you think of improvement, but now the treatment is central. So with just investment of 35 microns, that same patient is much better in terms of best corrected visual acuity. This is exactly 2 months post-treatment. And so still the epithelium hasn't recovered fully. And as you can see, the contrast sensitivity is better. The spatial frequency is better at all different levels. So this is again the Athens paradox, and I'm going to show you what I mean by the embedded. This is another patient with this refraction, as you can see here, at 6.5. And this is the ablation depth, 53 microns and 54. And now, if I decrease 5.5, yes, I will get less ablation because I elected to put the manifest refraction of that patient. But if I go back and I try to play around with the refraction to get to the lowest stromal ablation possible, and in that case, not much lower than the true manifest refraction, I end up with less ablation, yes, from 54 to 36. But now, if I look at the 6.5 optical zone, I have 35 micron and 37. And if I go back to 55, I actually still get 36 and 37. And that's the difference. So if you're not putting more spherocell, actually going large optical zone does not give you deeper treatment. Why is this important? Because the larger the optical zone, the more chance you're gonna nail the coma, which is the main problem of keratoconic patients. So we should think of enlarging the optical zone. And I usually go minimum 6.5 and typically sometimes 7. So from 6.5 as a minimum to sometimes 7, depending on the tissues and what I have as well. And finally here, corneal ring segments. Again, this is not new, it's old, but I think it needs to be combined with laser modalities. If we truly need to apply the mantra, the less, the better, because there are so much that can be delegated to the corneal ring segments. The way they work, they flatten everything in between. They flatten, again, what's away from them, the meridian that is away from them, and they steepen the meridian that is along them. And I'm gonna show you an example. Now, this is one ring to make it a bit less complex. And as you can see here, corneal ring segments introduced at the bottom of the ring will end up with a subtraction topography, as you see, kind of similar to what I told you, flattening just adjacent to the ring, and you have a steepening that is away from it, as you can see. Now, how is this effect being performed? Is it stromal change structure, or is it epithelial? Now, I think it's both. What I look by now, looking at all my OCT measurements and following all these patients, I saw that there is an improvement on 2 levels, the epithelial and the stromal. So look at the epithelium here, and look how it's thin all the way when it gets to the cone. So again, it's thick all the way here, and then right next to the corneal ring, and then it's thin all the way down. And that by itself, the thickening will bring down the steepness that you have along the cone. So part of it is epithelial, interestingly, a good part of it. Like you see here, so the thickening we have here is commensurate with the thickening just adjacent to the cone right before the cone, so adjacent to the ring right before the cone. This is a bilateral ring. You can see the epithelial thickening at the periphery and thinning, of course, at the top of the cone. While you have thinning right on top of the corneal ring. The cornea thins because you have elevation. And again, as Einstein showed us, the epithelium thins out on elevation and thickens on depressions. And again, this is the tangential curvature of that same patient, and then the one before, the one that I showed you before. And with corneal ring, you have a major improvement. And again, on top of the epithelial removal, improvement, look at the stromal, anterior stromal elevation. And that's the stromal elevation when we subtract the epithelial layer. So it's not your anterior BFS, it's the elevation when we subtract the epithelium. And this is the true elevation of the patient without the epithelium being taken care of, being calculated. So as you can see, pre-op, 45 microns, 1 week post-op, 35 microns, and then again, 1 month post-op, we still have an improvement of 30 microns. So there is continuous improvement both on the epithelial and on the stromal side. There is both a mechanical change and an epithelial change that are improving the cornea. And by the way, this epithelial thickening, we need to keep it in mind when we perform PRK on these patients. Now, along with intracorneal ring segments, there are the corneal allogenic intrastromal ring segments, or CAIRS, introduced by Susan Jacob a couple of years ago. Now, the way they're performed, they're exactly like corneal rings. The difference there from allogenic corneal segments. I really like to get corneas that are completely bad in terms of epithelium. I don't care. Sometimes you can get ionized corneas or cross-linked corneas. They're expensive. So what I just get really bad, crappy corneas in terms of endothelium, just take those away and cut them with the Trifine, the Jacob Trifine, and just insert them into the cornea. I like to insert them kind of dry. I call it the jerky technique because they kind of get quick. I like to perform an incision on the other side to pull them because they're kind of soft. They're not as rigid as the corneal ring segments. So the PMMA one, they're a little bit difficult, a little bit to introduce them, but that's fine. And you can squeegee the lamellar segment now inside to get kind of even when they get to the tunnel. Now, the advantages here are many. The advantage is that they don't cause melting. They don't cause rejection up till now. More importantly, you can put them really shallow, like at 250 microns. And by putting them shallow, the epithelial remodeling will be better, as well as the stromal remodeling will be better because you're in the anterior stromal realm where it's really structural. So I'm going to show you an example where a patient presents with keratoconus and having very deep corneal ring segments that are perforated, as you can see here, complete perforation with corneal edema. I had to remove that ring and wait a little bit for the corneal ring to for the edema to subside. And as you see, this was the topography before the removal and after the removal, and it didn't change because the corneal ring did not really help at that stage. So the patient had really bad keratoconus, and it's not the pellucid. People think the pellucid needs to have a 20% thinning down, and it's not when later when we see the pachymetry. So it's just a decentered keratoconus. So I ended up revisiting the cornea 2 months later when the edema subsided, but now I can't really go deep because the whole cornea has perforated. I have a previous tunnel. So what I did, I revisited with a corneal ring segments that is actually on top of it, about 100 micron, 120 micron on top, and 250 micron just next to the epithelium. You can go with a PMMA segment 250 microns. It will definitely cause melt, but with a natural allogenic segments, you can. And the importance is that it will elevate the cornea more. It will induce more epithelial remodeling and will induce more stromal remodeling because it's there on the anterior stroma. And what did I get as a topography change? This is the topography before, and that's the topography after the CAIRS. A huge difference. The patient is now 20/20 with, in another talk, I showed the difference and I showed the contrast sensitivity, and the patient is by far much better with a corneal ring segment, with an allogenic corneal segment. So that's another thing that is important in the armamentarium of the refractive surgeon dealing with keratoconic eyes. Of course, here we can touch it up with any form of customized laser to keep that improvement even further if ever needed. So, and finally, I'm going to show just quickly what we have as lens-based surgeries, just quick. So we have a couple of selections. We have the small aperture IOLs, and these are really great. I think they will have a great potential. The only problem with them is that they have selected range of powers, and they're not toric. So if a patient has a lot of astigmatism or a patient is high myope, we can't really go beyond a certain range of selection power. What is interesting at the same time is the small aperture sulcus implants. Both are made of hydrophobic acrylic material. The advantage of this is not an IOL. So you can go ahead and put any form of toric IOL, then put this sulcus lens on top. It will be a pinhole. Both have about 1.3 millimeter small aperture. So it will pinhole the aberrations of these keratoconic patients. And it has been shown that if the patient has a lot of astigmatism, putting toricity and pinholing even gets us a better visual acuity. So this is something we can have just in case the patient needs some form of cataract surgery. And if a patient still is young and doesn't need that, we still have the ICL or the phakic lenses. Now, these don't come in a pinhole fashion, at least not for now, but at least we can outsource the lower order aberrations to them. And this way we can keep the stromal ablation to a very minimum. Again, the less, the better. So the final take-home message here, I think from all this talk is one, debulk large aberrations with additive technologies like corneal ring segments or CAIRS. Keep the laser ablations to target higher order aberration, keeping the lower order aberration at the minimum and treating what is embedded in them. This way we can go large optical zone and be less in terms of stromal ablation. Outsource the lower order aberrations to lens-based procedures like phakic IOLs or pinhole IOLs or small aperture IOLs. In laser ablation, again, the less the better, and large optical zone whenever possible. We can always revisit these eyes later. So we have to keep in mind, we cannot just use all our cards from the get-go. Thank you.
Oh, thank you so much, Shady. This is, I have to say, amazing talk, honestly. It's, I mean, the way you follow those concepts, you truly brought a new concept. This is what the title, and it is genuinely a new concept, and it makes sense. Everything you said makes sense. And I have to say, I personally enjoyed it. You make me more hungry for more technology now. As you said, this looks like what we have, even the best tools we have, they're not enough, which is true. We need better and better, which is great. And I just start with the, I have a lot of questions. I don't think I'm gonna go through it because we already running on time, but I'll just, a couple of things from me, then we see what the audience have from other questions. When you talk about the corneal inlays, the CAIRS, You mentioned about the corneal epithelium remodeling. Is that the same what you see with the plastic rings, PMMA rings? Because it looks like there is a smoother remodeling. I could see there's not much thinning above the ring, the implant, the inlay, and less thickening of it next to it.
That's true, but it all depends on the depth you're using, because these tissues are, squishable, so they're not the same. But because you go at a much shallower depth, they do still give a good epithelial remodeling. But the difference here is that also they're broad, so the remodeling is on a broader level. But I see, at least till now, I see almost the same remodeling as I see on the corneal ring segments, on the PMMA.
And you said that you prefer to do some customized laser after the rings,
If needed.
If needed. And do you have any limitation on that? How do you change your traditional customized laser in this case?
So basically, what I do, if the cone is really large, I always run first my. Sometimes it's so clear. A cone that is in the 60s or 55, that's a lot, and I always like to tackle it with corneal ring segments first, especially if it's peripheral, of course. But otherwise, if it's in between, I run my calculation and I see the tissue ablation and I decide. If the tissue ablation is a lot, no, I'd rather first use the corneal ring segments, whether CAIRS or whether regular PMMA, because what I want is debulk the aberration and leave the laser to the much more refined, artistic, if you want to say, but much more refined treatment. I don't like to think about the refractive surgery as an art. I think it should be a science. I hate to say it's an art. It's not an art. It is a science. But I think it's we can debulk the aberrations and leave the laser for the fine treatments. It's like a laborer, it's like a painter, where you just want the painter to have 2 or 3 hours to paint a nice painting, and not let the painter, the artist, go and let him paint a whole wall. You know what I mean? So that's the whole thing. By doing so, by the way, we can also have less stromal tissue and have more predictive treatment.
Sure, amazing. So now talking about the trans PTK, you showed it's, for you, it probably works better than trans PRK.
No, I'm not saying. I did not. Yeah, in this example.
That example. So how did you decide in that example? How did you go with PTK? What's your yeah?
So as I showed you in this exact example, I did both treatments in parallel, and I looked and I saw the ablation map, as I showed on the slide, is smack down to the epithelial map. And then with the ablation map, without the transepithelial, of course, the regular mechanical ablation, I saw 13 microns of treatment on the cone. And when I looked at the PTK, the difference between the center and the thinnest point on the cone was actually 13 microns, which means if I plug on my laser 53 microns centrally, the laser will remove 53 microns centrally, but on the cone, it's, let's say, it's 40. So the 13 microns will be actually stromal tissue ablated. And that's almost the same. And then I figured, well, I can either do mechanical PRK, or I can do a transepithelial PRK, but transepithelial PTK. But doing a transepithelial PRK right now, with the technology I have right now, will end up with double treatment on the cone. I will end up with 26 micron. And in the future, when, let's say we have an OCT and we can import the map right into the laser, and that's actually something we can do right now. I think it's a matter of regulation, getting CE approval or FDA approval, but it's there. Then we'll be able to kind of take this map, ablate it all the way to the stroma, pass Bowman to simulate the same map. That will be the best treatment possible. But right now for that patient, I elected just to perform PTK, and I got exactly the same shaving on the cone and improvement in the cone.
Brilliant. And Shady, a great use of the OCT tomography, and fascinated how the examples you showed when you compare the posterior high elevation with the anterior. What do you tell people who don't have this fantastic OCT tomography, if we just stuck with the Scheimpflug tomography, which I think majority of us have? So do you think that could be applicable as well?
I think for Scheimpflug, we should not look at the posterior curvature, because actually we will have artifacts and we might deduce wrongly, and we will would never know whether this is true or wrong. So I think we should just base ourselves. I mean, we can use shine plug, but treat the anterior curvature only and make our inference from the anterior curvature. But I think for the general ophthalmologist who is performing some kind of topography guided treatments, I think we're good. We're still improving these patients. But I think if somebody is a refractive surgeon, I think an OCT tomographer is a must. And also a pyramidal aberrometer is a must. As a refractive surgeon, if we want to deal with keratoconus, we have to deal with it at a much higher level than a general ophthalmologist, right? Because these patients are referred to us, and we have to give something extra to what a general ophthalmologist does. I mean, both will end up benefiting the patient, that's for sure. But a refractive surgeon, in order to earn our name, and we need to be always at the edge. So.
Of course. Well, I could support your statement saying we have many examples where we looked at the Shimplong posterior data, cornea data, and I can tell you disappointing results because it's, as you said, it's not reliable for sure. Final question from me, just to clarify. So when you talked about combination, cross-linking, PRK, you talked about if you're doing combined, that's usually reserved for severe cases. And if you're doing sequential, that you reserve for those with better vision. Am I correct in saying that?
Correct.
Okay.
Because,
okay. Great.
Yeah. Because basically patients who have milder form, first, they might not need the PRK later. They might improve, they might flatten and improve. And two, if you ever need to revise these cornea, you're gonna just do some fine treatments, which we completely shuffled if you're doing a combined treatment because we don't know how this cornea is gonna behave. So for very mild irregularities, I'd rather cross-link first. On top of that, the patient's vision is acceptable. So the patient can wait for 2 procedures to happen if ever they have to happen. While in patients with very advanced keratoconus, I'm not gonna let the patient wait 6 months or a year before performing the second treatment. That's a lot of loss of time with poor visual quality and quantity.
Brilliant, brilliant. I'm cautious of time, and we'll have a question from audience. And I'm glad to tell you that the audience has not dropped by a single person. They're still with us, even though we exceeded 10 minutes. That shows how they're interested in your topic and with your amazing talks and answers. So I'll let Artemis now go through some of the questions we received. Thank you.
Thank you so much. Such an amazing lecture, and actually so much condensed knowledge in just 1 hour. I think last question, how did you transition to the allogenic intracorneal ring segments? Was it easy from using the PMMA ones in terms of getting the equipment and applying?
Honestly, to be honest, it wasn't easy. I think Susan Jacob is an amazing surgeon, and she makes things so simple. She makes them look so simple, but they're not. But in retrospect, now it's very easy, and I can share later tips to make it super easy. Yes, now that I knew my mistakes. So the number one is that we need to enlarge these tunnels more than the regular corneal ring segments. And what I do, I call it the jerky technique. I'm gonna release a video about it. I let these segments air dry, and by letting them air dry, they become malleable, just like beef jerky. I don't know if somebody is a fan of beef jerky, but they're exactly like beef jerky, and they slip so easily into the tunnel. And that's what I do. And these 2 tips have dramatically improved the insertion.
Amazing. Well, I think the question, Artir Radika, this is something we're going to learn together, because hopefully we both start doing here. Brilliant. Excellent. Thank you very much. Any more questions, Artemis?
No, I think everyone is very thankful for the lecture. Everyone is saying thank you, and what an excellent session that was.
Before I conclude, I just want to say, Shady, thank you so much. Honestly, amazing talk, a lot of good knowledge, a lot of new concepts, all make sense, all amazing. And I think will change the practice to many of us, those in the audience, or those who listen. And by the way, we get hundreds of people listen to the YouTubes, and I'm sure people will go back and listen to your talk. I'm going to listen to it again because I think I missed a few things which are really, really important. So thank you again. I'll let Artemis conclude. Thank you.
Thank you, Sam. It was really an honor, and I really enjoyed it. It's really cool to speak at the Cornea Club. I like it. I've seen previous talks, and I'm so honored to be one of the speakers. Thank you.
Great, thank you so much. And thank you everyone for staying with us so late. So I'm just going to remind you of our next sessions. So on the 14th of July, Professor Sadir Hanous will be talking about decimate stripping only, advantages and limitations. And on the 11th of August, Prof. Ken Mishal will share some top tips on pediatric cornea, which is something that a lot of people have been asking for. We had a lot of emails about that. Also to let you know that we can issue certificates of attendance from today. So people who have attended can ask for their certificate. And we will be soon launching our registration for membership to the Cornea Club. So you'll find more information on our website very soon about membership benefits and so on. So I would like to thank you all for staying with us tonight. And Professor Awwad, that was excellent. Thank you so much. And we'll see you very soon next month. Okay.
Thank you.
Thank you. Bye. Good night.